Alright everyone, go ahead and get started. Today we're going to go over advanced directives, and it's really just general information, and as far as your guys' questions are, we can get in-depth as we need to, or anything like that from your questions, and we'll also go over the changes in the EMR that are coming tonight and starting tomorrow.
No.
Tomorrow, starting Wednesday,
Right.
sorry. Lost a day in the middle. So people get pieces or all of these things mixed up sometime between last will, living will, advanced directive, and the healthcare wishes. We're going to iron all that stuff out, and then I'll go over the POLS form that was just ratified by the House, the Wyoming State House of Representatives in January. So last will and living will, this one's easier to comprehend. The way that I actually look at these things too is like these Russian nesting dolls. So they go really broad and they get more and more focused as you go down. This one's easy to differentiate. So the last will is what everyone has seen in the movies. It's basically a family dies and their kids are going to go where, the house is going to go to whom. That's what the last will is for. And it almost never touches on healthcare, and that's almost always the living will. Even in the state of Wyoming, if you try to file a living will with your last will, they won't let you. They'll actually take out the living will, notarize the last will, and file it in the county courthouse, and then tell you to file your living will with your primary care provider and the hospital. Okay? So the living will is really just a document detailing the person's wishes, so it is actually an advanced directive, and that leads us into this one. In this state, and a handful of others, 36, 37, 38 others, they're actually synonymous in the statutes. In the state of Wyoming, they're actually termed living wills in the statutes, and it's only when you go into the hospitals that you hear the term advanced directives. Right? And it's more of a federal thing to hear advanced directives, so I'll just use that term in the rest of this. And again, in our state, they're synonymous. But it must be people over the age of 18, meaning a parent cannot file one for a child in the state of Wyoming. I actually had that confirmed. They contain these following elements, which we'll go more into. The instructions, the designation of the POA, organ donation status, designation of primary care provider. This is the only piece, this designation of power of attorney is the only piece in an official living will or advanced directives that has to be notarized. Everything else can just be in writing or verbally to any of our staff members. And then living wills, does everyone remember the Terry Schiavo case?
Yeah.
A handful of years ago? So the living will goes into more of that scenario, into more detail in that scenario than our advanced directives might, because there was a massive use of life support in that case, and it was a legal argument about whether or not the husband had the right to decide what happens with his wife, or the state does. And so those cases, the long-standing coma and persistent vegetative state, the use of life support to maintain life is gone into just a little bit more detail if you download a living will packet, as opposed to our advanced directive packet, and that's really about it. Okay, so healthcare wishes is a portion of the advanced directive. Again, we're going farther down into the Russian nesting doll, and this is the minimum requirement that we are supposed to derive from patients when they come into our facility in an inpatient setting. We're supposed to know before we start treating that patient what they want that treatment to look like, basically. If they do go into arrest, what do we want? What does that patient want, and how can we meet that objective? That's basically, this is the minimum requirement. We're required by statute to give them the information on advanced directive, but they don't have to have it, right? They don't have to form one. We are just required to furnish the information if at all possible. But we are required to get their wishes. And if it is, I don't have any wishes other than normal, then they're a full code at that point in time, right? They just want to be saved. It's not just none. It's at that point in time, they have no extra wishes, something like that. So there always has to be something with healthcare wishes. And they can go in these 4 areas. They don't always have to. The big ones that we see a lot in nursing staff here, the big ones we see a lot are resuscitation and ventilation, probably, right? Mm-hmm. More often than not, they just want to be saved or not saved. They want ventilation, they don't want ventilation. You don't usually go into nutrition and pain management, but they can be in here, and we'll go over that a little bit. Any questions so far? Okay. So this wild pulse form that was just ratified by the House of Representatives is a new New thing for Wyoming, but it's not a new thing nationally. There's now 40 states that have gone. We were 37. There are 40 states that have ratified the PULSE form. So it's supposed to be a database and an active order set, yes.
Does this replace Comfort One?
I haven't figured that out yet, to be honest with you, because they're still saying Comfort Ones are valid. I think they might try to phase out Comfort One, like not give any more.
Okay,
But,
but those are still, if somebody
'cause they're
has a
still
Comfort
valid.
One.
Yeah, and Comfort One is easily recognizable by the band, so I think they might try to keep them around for a certain extent, but,
Except you have to ask people if that's their band.
oh, okay.
Because we had people that would take them off and put them on themselves. It was their spouse's band.
Oh.
And they were taking stuff off of them and they put them on themselves and they're like, don't do that.
Yeah, don't do that at all. So I haven't figured that part out by the state. By the state law, it does say that those are still valid if they were previously issued. So I don't know if that means that they're going to phase them out or what. They haven't released that information yet.
Okay.
So the PULSE form will actually look like this, and they'll have the Wyoming Department of Health sign up there. We actually are required not to change these forms at all, but they'll be in goldenrod. These are supposed to be initiated in the clinic, in the outpatient setting. They're supposed to be either by their primary care provider or the care provider who's treating them for their life-limiting illness, like an oncologist or pulmonologist, something like that. And other states have said that it's supposed to be the last 2 years of life or the last year of life. Wyoming did not go that restrictive. It's only those with life-limiting illness regardless of age. So somebody could be, just say, this is really common in our area, COPD, right? COPD qualifies you. Any person that's relatively healthy with COPD still qualifies for this life-limiting illness. And the difference with this PULSE form is it actually constitutes an active order set. So even though that physician does not have medical privileges in our facility, we have to abide by that order set by law in the state of Wyoming. So they can come in and a nurse can follow it exactly like a set of physician's orders until there's a new assessment done by that provider. Does that make any sense? Okay. So again, they'll be gold, and these won't replace any of the stuff that we already have. They can supplement an advanced directive portion, the instruction of healthcare wishes portion of their advanced directive. Like basically that's the general checklist, and then this is the roadmap of how to get there. So they can supplement it. They can replace that whole part of it if the patient would like to do so. But it can be a standalone document. Either way, it's all valid. Okay. For this, and there's a whole policy that's being approved right now. It's the healthcare directives and surrogate decision-making policy that has an entire section with this. So it does have to have certain elements that make it valid. One of them, and the most important, being a physician's signature and the patient's signature on there. The really cool thing too is that the patient can actually check a box or initial a box on here that makes it illegal for that person that they designate as their POA or their representative. It makes it illegal for that person to change the wishes on the form, because our normal advanced directive doesn't have that kind of caveat on there, and there's really no legal recourse for when a person does do that. Okay, so here's the good breakdown. Every adult, life-limiting illness, regardless of age. This one, again, it's supposed to travel with the patient across healthcare systems. Wyoming hasn't figured this out all the way yet. You have to post it in your house somewhere really easy to see, so EMS doesn't forget this or anything like that. So it's going to be a lot like your Comfort One problem, I think, at first. Where are they going to post it? How are we going to make sure that everyone knows it exists? Yeah.
How about it on your fridge?
Fridges was the place that the File of Life was saying is a good place for it. Wyoming State just said somewhere that can be easily seen, like on a wall, on the door, just somewhere. Okay, so we'll go into a little bit. That was the what. This is the how, why it's actually important to have these conversations with the patient. And I'm sure that you guys have seen this, but this is an easy statistic to see that although people are living longer, but they're also dying in the hospital more than at home these days. And almost the entire amount of healthcare spending that a person has in their life is mostly taken up in the last 2 years of their life. So they're in the facility. We're providing a lot of care in that last 2 years, and then sometimes not even asking them if they want it. So it's the fault, it's not really anybody's fault, it's just that this is what has happened over the last 100 years, is creating this massive funding issue in the last 2 years of someone's life. But we really just want to provide patient-centered care, and if you look at some of the research, this is a people on the street study, and 70% of them, when they just stopped them walking around on the street, asked them if they wanted all of these life-saving treatments if they had a poor prognosis, like 1 year or less to live, and most of them said no, 70%, right? But then also this is cancer patients, DNR orders were linked to higher quality of life because they were able to focus on things like comfort and getting the family in there, actually what the patient wanted at the end of the life, so their last remaining time was of high quality. But then, if these things are true, then this review of about 10,000 patients in Canada found that only 31% of ED patients over the age of 65 had these advanced directives formed. So, exact opposite of this, 70% of the people coming into these EDs had no idea what they were wanting, but they were just going to throw everything they had at them to save their life, even though they might have wanted that higher quality of life, and they might not have wanted all those life-saving issues, but people weren't having that conversation. So, for the how, what are some barriers that you guys have seen in having this conversation with the patients?
Anxiety.
From the patient themselves?
Yeah.
Okay. And how do you get around that?
I say try not to freak out, but I need to know what you feel about it.
Okay, all right.
Yeah.
That's one way. Do you preface that?
Before they go into surgery and they're like,
Yeah.
oh, what about this?
Yeah, don't freak out.
Yeah, don't freak out. I got it.
All right. So nurses in the OB unit actually said that they prefaced it with, I know this is a deep question, but I have to ask you this. So that's one way around it, right? The point is, though, that when we're getting through these conversations, so in all of our research that we did, we actually did a shorter or a longer version of this presentation for the University of Wyoming students up there. But all of the research showed that it was communications, either you not having the conversation, the patient not having the conversation with their family, the patient not understanding the conversation that you're having with them, your belief bias as a healthcare provider, and the family's belief bias. One of the things that was really big with OB is that Jehovah's Witnesses patients that will refuse to accept blood, and they're completely healthy, and then need blood transfusion, and then don't refuse one and then die. So they're basically just saying, I'm accepting death at this point in time, even though it's a pretty easy fix, right, to you. And also that most healthcare providers get bashed in their brain that they're saving lives all the time. And this is sometimes hard to accept, that you're just going to let this person die and not do anything about it. But that's what they wanted. And then also, this is one of the big ones too, family dynamic, right? That's what we heard a lot of times. Apparently in OB, that's who I've given this presentation to already. They say that this is what happens more often than not when they try to have this conversation, is it sets off this existential argument with the family. That they're like, okay, I'll come back in 20 minutes when you're done yelling at each other, which is interesting. Okay, so this has been around for about 10 years. This is the Institute for Healthcare Improvement has a conversation project. And what they set out to do, is to create a system where the patients were given every right to have this conversation. Everyone was getting the information that they needed to from the patient forward to cater their treatment at the end of their life. And the way they wanted to do that was to try and make healthcare providers comfortable with having the conversation with their family and loved ones, right? So if you can think to yourself, what matters to me at the end of my life is, and you have an actual answer, then you're ahead of most people. You're ahead of a predominant amount of people that couldn't even say what it matters to them as a healthcare provider at the end of their life. You guys have a good frame of reference for everything that they could offer at the end of someone's life. And if you can't answer this question, how is a patient, a layperson, supposed to? Right? And I did send out their toolkit packet a couple weeks ago, maybe at the beginning of May. Crap, it's been that long ago? Yeah, okay. So, and you can go to this conversationproject.org and get that toolkit packet again. And it really is a start-to-finish tool on helping you conceptualize your own care at the end of your life and what you might want. Because the statistics were over 65, but it really could happen to any one of us in this room, and we have to be ready to form those wishes really quickly. But when you are able to get this to the patient, what matters to you at the end of your life, then you're going to start getting some legitimate, real answers, and something that's actually actionable and useful. We're going to talk about the forms that we're going to be using here, the new form here in a minute, and it's supposed to give you an easy way to help the patient conceptualize what actually matters to them at the end of their life. And we're looking at, we want to actually provide patient-centered care again, but this does help truly form the whole care plan with the patient. Because you want to know what that patient wants you to do start to finish. And if you don't have this as the punctuation of their care plan, then you're not going to know. The whole thing's not going to be formed with the patient. It's not going to be patient-centered care. And the IHI, again, said treat this like any other procedure. The thing that they said was if you're going to provide a medication, don't you want to know the allergies first? You don't want to provide a medication to a patient without knowing if they're allergic to it. It's the same kind of thing. You don't want to treat a patient without knowing what they want at the end of their life. You know, if there's a procedure like a surgical procedure back there, and you don't know that the patient doesn't really want to be resuscitated in that procedure, and you do it anyway, you don't want to go that route. Okay. So with that all said, this form this is a section from our new patient healthcare wishes form. This is almost the entire form. This is not just a section, but there's a portion at the bottom that gives you a chance to check who all is in the room, and then the patient and or representative sign it, and then a staff witness signs it as well. But it's an easy way to go through these, so it's not just do you want to be a DNR, do you want to be a DNI. It's what matters to you when you have no pulse and are not breathing, and has a pulse and or is breathing, and this will go into ventilation, defibrillation. So there's a lot of medically strong words in here. You're supposed to be checking the boxes while having this conversation with the patient. Right? The nurse or care provider is supposed to actually be having this conversation and filling this stuff out and then confirming with the patient that this is all we said. Okay? If we hand this form to the patient and say, fill this out, I'll come back in a second, we've already failed. And this system is no different than our current one. Okay. And then down here is this is artificially administered nutrition. So the caveat on here, the doctors want oral fluids and nutrition must always be offered if medically feasible. We're not going to starve our patients is basically what that says. Any questions on this piece?
Are we having all outpatients, all inpatients, who's all in this form?
Inpatients for right now.
Okay.
Yeah. So your outpatients, they per our policies right now, we ask if they have one, ask if they have an advance directive, and if they would like to form one.
Okay.
And that's only in same day, right now. So
what am I doing then? Am I asking people if they want to be a full code and all that stuff? What am I asking?
currently, yes. Yeah.
Okay, so what if they tell me that they don't want to get that nutrition stuff or be ventilated or have a tube put down?
Okay.
Well, they're already in surgery and they have a tube put down, so I
Mhm.
mean, you can see how things get really confusing.
Sure.
Well, there's a difference between a breathing tube and a feeding tube, though.
Yeah, well, I mean, we're already having intubated though, I mean, are we gonna pull out the tube and say, okay, they don't wanna be resuscitated?
No.
With those, anesthesia actually has to consult with the patient, tell them what they're planning on doing, and the patient has to agree to it. If the patient doesn't agree to being intubated during the surgery, then anesthesia needs to let them know what options they have on whether they can or cannot do the surgery that way, and then that's the patient's decision on whether they continue on or not.
That is
We
correct.
gotta get anesthesia on board.
So this is something, and this is why we're rolling this first out into inpatient areas, because it's pretty cut and dry at this point for inpatient. This gets filled out and scanned into the record, I'll show you that in a second, and then tackling outpatient area years specifically, because there's a lot of argument about whether or not it's even value driven, and that's a stupid argument, because you're still actually doing what we should do for the patient, making sure that what we're doing is right for the patient. When we do the consent forms, the consent usually has in there, this is what we're doing, and it's going to require intubation or whatever else, and if the patient signs a consent with that explanation, then they've consented for the intubation for the procedure specifically, but that does not blanket deactivate a DNR or DNI. It's procedure based, it's only for that procedure, and then in the actual, and that's a good question we had as well. Is it 48 hours after that DNR is actually held? And there's not a policy saying one way or the other. So
The policy for DNRs that we put out, that's not through the approval process yet, says that it's only through phase 1 recovery.
okay.
Once you get to phase 2 recovery, then the, whatever.
The DNR gets done.
Yeah.
Yeah. So, and that actually can't be for everybody. You know, if you ask them and they say, no, I want to be a DNR still in the procedure, we have to follow that. So it really does. That pulse form I went over beforehand, that has to be across all paths of care, I think is what they call it. So even in radiology, if they walk up and say, I have a pulse form, and they code in there, you can call and have a response, have nurses come and everything like that to get them out of that area and into the ED, but once that person's there, we have to honor those. We can't do anything.
Well, I just want to know how much documentation you want from me. Can I say yes or no to stuff, or do I have to, how much elaboration do we have to do? Can I say?
The nurse's quadrant note has, that question, what is
Wishes.
the patient wishes?
Yeah.
So that's where we're getting all these
Sure.
subjective statements.
And I'll go over that for you here
Okay.
quick. And what we'll probably end up doing in the meantime, because we deactivated that,
Oh,
we got rid of that.
that no?
So it could, not the note,
Oh.
just that line, so we can actually use this instead to get away the high liability stuff. And then what's at the bottom here is additional comments and the signature lines and stuff like that. And so we'll probably end up rolling this out in your area, to be honest with you. So this is what you're talking about. This is this is the note here.
Right.
So part of the finding that we had was that this just said something similar to this. It just says CPR or none, or short-term intubation was the actual finding, right? So it was just vague enough that we don't have a definition for it. We didn't, if they asked, the surveyor asked 5 nurses and they didn't come to a consensus of what the definition was. Differently, obviously, it wasn't, they were all in the same room debating the validity of it. It was, they asked and said, what would this mean to you? And not everyone matched. Okay, the other part of the finding that we had was that family was saying one thing altogether, and our documentation says a completely other thing altogether, but there's never anything that shows that we were on the same page. So the form itself is supposed to be our gap between this and also supposed to show a consensus between the patient, family, and our facility. So now this is what some of our errors came to. And this further consultation going to case management, it was just going actually into the ether, right? You guys weren't even really seeing when it was coming up and everything like that, so that's also been deactivated. You still can order a consultation with case management, you just have to go in and manually do it. So this is what it's going to look like now, and this is why, if you guys are using that line actively, we'll just get this form in your department. So, do they have an advanced directive? Yes or no? If they say no, do they want the information, that part's still existing? If they say no to there, it'll just take you to this conversation of patient wishes piece. And then we'll ask you yes or no. If you say no, again, you have to say why, but if you should probably just say yes, you'll have that form you'll fill out with them and scan it in. For the same day, you can probably have the form, make sure it's in the chart, and then send it down to HIM. It's supposed to take out the actual vague free text.
And is it gonna repopulate? Because that's another problem we have. I have somebody come in for colonoscopy when they come in for me, and I gotta redo.
So here's the difference. If that facility form, because of its non-official nature, cannot go for more than one encounter.
Okay.
So if it's somebody that comes in, visits a lot, I would push them towards forming that advanced directive or the pulse form with their provider or something like that. Because if they're just coming in every month or something like that, we're gonna have to ask them every time.
So we're gonna have them, even outpatient surgeries, fill this form out and scanning it in.
We'll have to discuss in your department afterwards, because this was originally meant for an inpatient area where we're trying to tackle the response to our findings directly, but there is a valid use for it in your area. And I think that we'd probably have to go with that. Melissa will have to make a meeting.
Yeah, we'll have to take it out of pre-admit testing, though. It'll have to be done in the same day, because the anesthesiologist needs to talk to the patient before this is filled out.
I like that idea.
Yeah.
So does this replace the advanced directive?
Yes, and it'll actually be called Advanced Directives Healthcare Wishes.
Okay.
So it will actually, and it's actually advanced. So this is where it's advanced directives, not advanced directives, but the note's in there that way, and that's cool.
So
It's said like that a couple of different ways.
that one piece of paper will replace the booklet.
The booklet can still be, because that's the official advanced directive,
Uh-huh.
so they can still go through the booklet, and you can notarize it and everything like that in there. That it doesn't replace it. It's basically just if they don't want it, if they don't want a copy of advanced directive, or they don't have their copy of an advanced directive, then
they
our
fill
form.
this out.
Yeah.
Because, I'll be honest with you, the booklet's intimidating for most
Sure.
people.
Sure. Who hasn't seen the booklet?
Oh, no, I have another question, sorry.
Okay.
But no, I haven't.
All right. Yeah.
So if they have an advance directive, then, and they have it, or we have it, or something, then we do not need to do the wishes paperwork.
Yeah.
Okay.
If you go through this again, it'll say yes, and then yes if they have a copy, and then it'll actually bring up another line that just says, did you review it with the patient? Because you're still going to confirm that those are still their wishes. Yeah. And then scan it in. And it'll only save as partial. We're still working with OB on what their workflow is going to be, but it'll only save as partial until that document is scanned in.
And then if they have an advance directive, it goes from one treatment to a month later, 2 months later.
If it's an official advance directive, until they create a new official advance directive or specifically ask you to create this healthcare form and scan it in to replace their advance directive, then it goes by as many encounters as they want.
But the wishes form is only for one.
One encounter. Good question.
So if they're below 18, do we just not even do this note, or do we put patient who's under 18?
No, you
or-
can actually ask their parents what the wishes are,
Okay,
but they cannot form an official advance directive in the state of Wyoming for their under 18 child.
okay.
The PULSE form, you can.
So what if you have a child that is, okay, not terminally ill, but has like advanced CP or, I mean, just doesn't have a good quality of life and they get that last, like bout of pneumonia and,
You can push them towards, if at that point we are moving our PULSE forms into pediatrics for that case specifically, but if you get there, they just couldn't, again, form an official advance directive, and there's really not much of a need to at that age because the decision-making ability falls directly on the parents as a first line anyway. So you can ask them for wishes, and you can set that parent up as a representative, and then essentially it's no different. But you just can't form an official advance directive, like a notarized official living will / advance directive.
but the parents aren't going to be like, how do I put this? Culpable for their child's death if they choose not to do advanced care.
No, I mean, you're still asking their representative.
Okay.
Yeah, and you can still do that. It's just that forming of an official advance directive in the state of Wyoming has to be of someone over the age of 18.
Okay.
So do you want us to put like full code as per parents' wishes on pediatric patients or something along those lines, or?
You would still do the wishes form with them.
Okay.
There's a place for a parent to, like, you can check parent guardian. The form itself, again, is supposed to just make it easier to conceptualize some of the stuff that they might not. Because when you ask them, do you have any end-of-life wishes, they go immediate, like, oh crap, what does that even mean? It's just supposed to help you give the patient a little bit of a conversational help.
I just,
Yeah, Amanda, did you have something?
Yeah, so is the scanned advanced directive document historic? Or how,
Yeah, that's always been there. So it's, it just, at one point in time, was only the advanced directive.
so it's the scanned, so a new patient comes, a patient is here a month ago.
Yeah.
And I did this, and I have their advanced directive, I scanned it into that note,
Mm-hmm.
and it's in the record. Patient comes in a month later, I open this up again, because this is a new visit.
It does pull that image forward. It
yeah, you
does.
just click on it and it'll.
And that's new, because that hasn't been in the past.
Yeah, it's
Yeah.
never been historic in the past.
So it does,
House.
it does now.
I've been doing it for ever. You just click on it and it does the little twirly thing and it zaps it into the record.
Yeah. Well, regardless of whether it has or hasn't been, it does now. It is right now. It's functioning, from what I gather, fairly well. So if it's the patient healthcare wishes form, it'll pull up the old one and they'll still have to fill out a new one. and I don't know about how that works as well. We've tested it. We're waiting to see what actually happens and works in real life. It works in the test environment, so. They were, yeah, I was saying, people have been able to pull up historic advanced directives of late, so that is working. I don't know
And
how
I'm not
well.
talking about like old, I know how to,
Complete
like,
documents.
old notes I
Yeah.
can pull up. But I'm saying, so somebody comes in and it says, yes, I reviewed this advanced directive
Mhm.
with the patient, but how do I know that's the most recent advanced directive if I'm looking at one from a month ago that it, like, is there any way to say, yes, I reviewed it, and this is the one I reviewed with the patient? Like the actual document in a note,
Well,
not an old note.
Because what happens, every admission, there's an advanced directive procedure. We do it, we sign it, it's done. They come in a month from now, you get another advanced directive procedure. You don't see in this visit what was scanned in the last visit. With the way you do it is you go and you open the documentation from that prior visit. It doesn't pull forward into each
It's
advanced.
repopulated.
Yeah, it doesn't repopulate.
really, it did.
No.
It did when I was up on the floor the other day. By the way, we could take a look at it.
At
The
very
assumption
least-
is that no, you would not be. You would be pulling up that document if it's the document that's there, and going over that document with the patient. And if it's any different from that document you have in your hand, filling out the new wishes form and getting that
And just, there's been a lot of upgrades since we built QCPR. But scanned documents are not historical information unless some upgrades have made it historical information. And if it is still not possible to have scanned documents be contained as historical information, at the very least, what would be helpful is to know which procedure has the document that's actually scanned. So as an example, if you search for advanced directives, a patient who's been here a lot, there could be 15 of them.
in.
They all look the same. You don't know, and the patient said, yeah, I do have an advanced directive, and I gave you a copy, I don't know when. You have to go and open every single procedure to try to find that scanned document. But there's a way where there's a field, and you can put a trigger on it to where it could say something into the title to know this is the actual one that has the document in it. That's just a suggestion.
Yeah, and I don't know. I don't know if
you
that's
cannot,
it.
or if they can't have scanned images be historical, and I don't think they can unless things have changed.
Sure. I mean, it worked up on the floor, but in the absence of that, it doesn't, if they have an advanced directive, they say they do, and we can't find the copy, you fill out a new form and get the wishes in there. But like I said, it only works for that encounter. If the wishes jive, you're still asking the patient what their wishes are,
But
and
the
then you're not
wishes are not
touching
an
their.
advanced directive, because it's not notarized or living will. They're two different things.
Yeah, the wishes are part of the living will and advanced directive, and does not have to be
Are that
notarized.
form right there?
No, this is just in our facility.
Yeah, that's not a legal document.
It doesn't have to be.
That's not a
The
living will.
The wishes don't have to be notarized. The only portion of an advanced directive that does is
So
the
that-
designation of a POA.
So if you have both and they're not the same, which?
It's the newest one, always the newest one.
So if we have this one filled out, if the physician have to sign this or somebody has to acknowledge it?
Staff witness, so
Staff
whomever,
witness is
yeah,
fine,
whomever.
And then you let your people know
Mhm.
what their wishes are.
Yeah, because beforehand, all the patient had to do was tell you, and then you go, okay, and then type it in. That's it. It doesn't, this never had to be acknowledged. Yeah. Questions, other ones? Seems like we're getting on a lot of questions here.
Clay, part of what I do for care transition is help patients fill out their advanced directives, and I often do that at home.
Yeah.
And so, it's not unusual for me to have a couple or a patient who maybe has not been seen maybe for 6 months here, but have called me and said, can you help me? So when they fill it out, we don't have anything to attach it to. So it's often sitting in health information management until it can be attached to something or someone can put it in. Do you know if that's
This has been
process
something that we've been
has
working on.
improved? Okay.
Yeah.
So we're working on that right now. We
Okay.
actually had a conversation with them about QuadraNet because they do need an encounter to attach that
Right.
to. So we have some things out, some questions out to some QuadraNet folks about how they do it. I really think it's a matter of just deciding in our organization if there's a patient type that we want to create or a visit simply for the purpose, Greer, of attaching that documentation. So we're working on that internally. We don't have a solution right now, but
Okay.
we have a group that's working on
Yeah.
that.
Good question though. Okay. Anything else on this? So again, to reiterate that this here is going away when the roll happens. Okay? So we'll get the forms in your area just to make that. We're gonna have a little area, a little time where we might fail a little bit on this, and we'll just get those wishes documentation. I mean, this is a transition. Transitions can be rough. All right, so this is just some additional info. Everyone chime in if you'd like. So for Title 25 patients, this is something that we've actually dealt with quite recently. They actually are covered under Title 25, which is the emergency detention, and Title 35, which is the state statute for all hospitals and facilities. So under the initial Title 25, the patient has not lost their rights at all. 0 rights loss, okay? Until their final hearing, when they get court ordered to an inpatient facility, does the state of Wyoming subsume the decision-making ability of that patient? Okay? Now that does not count when the patient is acutely psychotic or unable to make their own decisions for a medical reason. It's noted. Then it falls on to the state or whomever is next of kin at that point in time. But if the patient is just incredibly depressed, but otherwise can consent to their own treatments, they could form a medical advance directive while they're in our facility. Yes?
Does that diagnosis have to be by a psychiatrist, or what type of diagnoses fall under that psychotic type?
It's really only if the hospitalist here feels like they are of the mind to make consent. It doesn't have to be like, I mean, if they're sitting there and not alert to person, place, and time, they're probably not going to let them make any of the other healthcare decisions as well, and are going to farm it to whomever they have to sign the consent, be it a guardian or a next of kin or something like that, right? So it does not have to be a psychiatrist saying this person's acutely psychotic. If they're not oriented to that point, then they probably aren't going to be making the decisions. It's up to the clinical team, though, to make that decision and chart it that way. The other caveat is that if that medical advance directive, the use of this is to try and facilitate a suicide, we can't follow that either. Okay. So they are DNR, and then they try to shove a whole bunch of, like a sheet down their throat or something like that, we would have to yank it out and treat them. They could not, in our facility, file a psychiatric advance directive. That's a completely separate issue. Okay.
So conceivably, somebody could go from a DNR to a full code.
If you can actually, if you know for sure that DNR, when they came in, patients say they were a DNR and they came in for a suicide attempt, you can say that you're on high watch. Basically, at that point, you can say they're a DNR for medical reasons. But if their behavior is what caused that resuscitation attempt, then you would say that they're full code. If they actively tried to kill themselves and use that DNR to carry it out, you have to treat them. And that's not really like an ethical area, but it is like, this is a state law again.
No, what I'm getting at is somebody could come in and maybe they've had a suicide attempt, or they're acting psychotic, and they have a DNR, or they have an advance directive, and then when they're titled under court order, the court is now responsible for them, and now they can make them a full code.
They can, yeah. And in most cases, you're required to.
Yeah.
When they hit that final hearing, unless there's like if there's a medical underpinning there, and they have a DNR for a medical reason, then the court would have to take that into effect. But again, though, the court would have to decide what you do. Yeah, this little 4 bullet point piece here is just a drop in the lake of the gray area that is these patients. But at least this is some guardrail a little bit to give you something. And then the POA advocate representative piece. So all of these can be surrogate decision makers. That surrogate is also another name for them. And as far as we are concerned and you're concerned in the field, the advocate and the representative are exactly the same thing with these patients. Exactly the same thing. They're usually, if you look at CMS, they might call them representatives. If you look at Joint Commission, they might call them advocates or representatives. If you look at it doesn't matter. Until you get in a legal setting, those things don't change.
Is it kosher to put patient state spouse can make all medical decisions
Yeah.
on my behalf?
That's all they're doing is designating an advocate or representative. That's
So
all
if
it
they
is.
don't have an advance directive and this is my wife knows my wishes, they can make the decision?
Yes.
And I can type that in there?
Absolutely.
Good. All right,
Yeah.
wonderful.
Because all they're doing is saying that she's my representative,
She knows my wishes.
and that's it.
And what if they're not a spouse? Are we still honoring that?
Yep.
Do they have to sign the consent form as an advocate for that to be legal?
They don't have to sign anything for it to be illegal.
I just have to document that they said this is the
Yep,
advocate.
that this is our designated representative. So that's the difference, is that there is in that healthcare directives and surrogate decision-making policy, there's a hierarchy of people if they don't designate someone and then they become incapacitated, right? So the state of Wyoming says that if a patient picks someone, even if there's someone off the street, like I just happen to be walking by whistling a tune, and he's like, that tune's pretty sweet, that guy's gonna be my representative. We have to abide by that, even if I know nothing about that patient, that person is gonna be the representative that makes decisions, right?
Well, we have a notarized POA on record.
And they choose
You can,
someone.
it's the first one, so power of attorney.
Is the
And
first one.
so a power of attorney though is a little bit different. So a person's power of attorney they can establish. And the only time that it actively negates itself is during a divorce in the state of Wyoming. So if you have a power of attorney and it's a spouse and then they've divorced, it becomes invalid. And that's a little bit weird because you're pretty much relying on that patient to tell you that they're divorced. And we can only do what we can really, right? We're not gonna know all about divorces in this area and know to cancel POA, so they do have to tell you that. But a person can strike a POA and designate a representative. A person can state a representative during that encounter that supersedes the POA. But we just have to make sure we're asking those questions. Because it does take a notary to establish a POA. It does not take a notary to remove one. So you can actually just say voided POA, patient signs it, and then you're done. If you want to go that route.
And they can change their decision for the advocate representative as many times as they want to.
Yeah.
So after surgery, they decided they really didn't like that song he was singing and decided that they wanted somebody else,
Yeah.
they can change their mind. So you can have, they can do it multiple times
Yeah.
during the course of an encounter.
So are the representatives limited in the HIPAA direction, like only included if, end of life things are happening? Because we have the representatives and advocates come through and I've kind of tiptoed the line of like, how much can I tell you, like, they're doing good after surgery or,
It's a good question.
HIPAA wise, if we can.
So there are a couple of restrictions for HIPAA and when they designate a representative versus a POA. The rule of thumb is that advocate gets access to literally everything on a couple of occasions. While they're going through all the pre-stuff, while you're signing all the documents, they've designated this person as the representative. What they're saying is that this person has the right to all the stuff that you're talking about right now to me, right? They can sit through here unless they tell you this is my representative, but I want them out for this point in time. Then you can go ahead and open up a little bit and go through all the stuff because the representative is supposed to understand everything just as much as the patient is that they're citing. So you can go ahead and tell them about the procedure and everything like that. Afterwards, again, exactly the same. This person's my representative. That means that they're going to be privy to my medical knowledge for this visit. So you can go ahead and come back and tell them they're doing great after surgery. We're waiting to move them here and whatever else. Now what that representative does with the information is completely different. They can, if they start blabbing and the patient's angry about that, you can just say, well, I told your representative and we're in the clear there if that's something you're worried about. What you would hope is that representative, that patient picked because that person can be a go-between between family and whatever else, and then it's a good communication hub. But you've done your due diligence by telling that representative so that they're just as informed as the patient is about their care. Now, the only stipulation really is that afterwards, if the patient is still incapacitated, like constant state of incapacitations, say they're an elderly person and they always are a little bit AMS, and they had a power of attorney established prior, right? That power of attorney goes through multiple encounters, and they can have access to the medical records when the patient's not in the facility. So they can call up and request medical records for that patient when that patient's not here. A representative or advocate cannot do that. That's the one stipulation. So if they leave and the patient is still incapacitated, or not rather, we wouldn't know if it was just an advocate or representative. That person couldn't call and request information from that visit once that patient's discharged. That's where HIPAA kicks in right there.
Makes sense. And the advocate is not responsible for the patient's finances.
Yeah.
So that's something else that's contemplated too.
Yeah, it's not that if this person is not going to be paying my bill if I can't. It's really just, it's a surrogate decision-making agreement, basically, between that patient and whomever they decide is going to be okay with it. Yes?
Just a comment on your thing, if you still feel uncomfortable about what, you can share, before you take the patient back, I would just ask the patient, you know what I mean, as your representative, is it okay if I share everything
update
with
them.
them?
Yeah.
Yeah.
Because we can,
Before, yeah.
yeah, and we can say those blanket things like a representative always has this information. But if the patient really doesn't want them to know, they just want them to be here to, maybe their whole thing is that my representative is going to drive me home and that's it really. Then it is good to always, the rule of thumb is literally always have the question, or always have that conversation with the patient. Because, that extra 30 seconds of the conversation might mean a completely different thing to that patient.
No, I think this is have to incorporate that.
Any other questions here? So, in summary, really, the patient is the most important component of the care team. So when you're doing this piece, what you are doing is making sure that you can cater the entire stay to that patient. And the only way we can do this is really to talk to that patient. Spend the extra time talking to the patients. Get to know what they really want. Sometimes, really, any time that the patient is here, you guys, as a care team or care provider, you guys get a chance to be in a really emotionally charged portion of a patient's life. And it can really just be it might just be another day for you, but that person might not stay in the hospital again for another 6 months or whatever else. And so to them, it's not run of the mill every day. So we do need to talk to these patients. And you can use the tools and the forms. Charlene talked about that advanced directive packet. I'll talk to you about that in a second. And then Quadrament. Some thinking about Quadrament when we look at everything like that. It's not always easy to document, to tell a story. So if you have that conversation with a representative or with a patient about their representative, and they've designated a representative, but you don't have anything else in there to say, representative should not get this type of information for the patient. Where are you going to put that?
Yeah.
So
it's not going to come up automatically anywhere and flag you.
So
privacy or something.
Yeah, exactly. And I will tell you that from sitting in that room with that surveyor, this doesn't come across. The story does not come across in Quadrant. So many times we've had to rely on the patient or the staff member to remember the care they're providing 100% to preclude some of our findings. Right? That's a precarious situation, especially for those nurses, because when we have a deposition going on right now, when the actual event happened, 2012. Can everyone here remember what they did in 2012 with one patient? Right? So do yourselves a favor along with doing our patients a favor. And Christy's in here and she did a full thing on it. So if you haven't seen it, first watch her PowerPoint presentation on documentation. But secondly, throw in those notes. Throw in that story if you have to. Because it's not going to, you are really going to, enjoy in 4 years if you're at a deposition, having those random notes that you throw in there. They go into business. But from a surveyor standpoint, they love that. It looks like you're actually caring for the patient, you're following that patient through, and you're actually trying to treat the patient as a patient instead of going through the notes and documenting to get through notes. That's what she actually said while she was here. It looks like you're just documenting to get through the notes.
Because there's so many of them.
Yeah. And that's also why we just repurposed this one and made it to where if the patient does change their wishes in the middle, there's a follow-up note now that's exactly the same as the old one. It just gives you the option to scan in a new one. So then you're covered that way for liability reasons also. So there's the original form on stay, and then a new one that shows a progression and change of wishes, and then a new timestamp and scan. Hey, any other questions? Filing an official advance directive is, Charlene, I'll go into that book real quick. The book is kind of large. An official advance directive book from the state is pretty large, but it is really, yeah, it is in its essence this for the healthcare wishes piece. If they were to go with the pulse form, is really their effort into trying to condense that piece down, I think.
Yeah.
But it does go into the pieces. It's actually easy to follow. It's just large. So don't just hand it to your you're not going to, again, just hand it to your patients and walk off. I mean, ask Greer. Greer goes through that book with a lot of patients all the time. It does take a little bit of babying going through it. But all of that stuff is incredibly important, and that's really what you want to impress on the patients, that we're really trying to make sure that we are providing care that you want. So going through this large booklet is not going to be that big of a deal if I'm here going through it with you. You don't have to memorize everything. We're going to still get on some understanding that this is what you're wanting if you happen to get confronted with an end-of-life scenario. Yeah. Yes?
So with the anesthesia, we do have, those particular circumstances where I'm a DNR, but during surgery I want it suspended or things like that. What is their proper way to document this? Should they be doing this with the patient and we scan it? Or, because I've seen them literally write on the bottom there, anesthesia consent, discussed with patient, suspending DNR, and there's no...
They're documenting it in their pre-search or their pre-anesthesia note. They're going in and documenting.
So that's the where I should be
They're saying that
encouraging
the
them to
physician's
document.
aware of it.
Yeah, they could do it there. They could, I mean, the consent, if you actually put it on the consent, that's fine
And
too.
it seemed legit to me.
Yeah.
I mean, they signed it.
I would say the
It's gonna
handwriting's a
be
bit
that
on the
time.
fishy side.
Yeah.
But, I mean, putting it on the consent seems legitimate to me. You'd have to personalize the consent though. You couldn't just have it on every.
Okay.
So, because they would also, if you were going to do that, they couldn't just sign on the bottom. They would have to initial, because they're consenting to two separate things at that point in time. So they would have to initial on the line and then sign at the bottom of the consent. But beyond that, that's a fine way. Doing the charting and the pre-anesthesia gets it out of the way as well. Because you're at least getting it into the charting that the conversation took place and then it did alter what they wanted for this period of time. So at least you're getting that in there.
And that's the only place that needs to be documented.
As far as that's concerned, yes, it really is.
Perfect.
And some of the surgeons are very angry that there's not a blanket policy that states that every person that consents for surgery gives up their DNR. Like it automatically is suspended for 48 hours or during the course of treatment to phase 1.
But then the doctor needs to put the DNR note in, right?
Yeah, if the patient decides they want to remain a DNR, we need an order in the computer before they go to surgery.
Absolutely, yes.
And that's something that the physician, the surgeon has to do.
Yeah,
The
physician
surgeon or
has
the
to.
anesthesiologist, either
Yeah.
one of them can do it.
It
But
has to
should
be a physician ordered
Yeah.
in the system. There has to be an order
Same
there.
for suspending it? An
No,
order
no,
in
no.
the-
No, if you're gonna maintain it, if they're gonna maintain that DNR, then you put in the order. If they're going to suspend it and it's an outpatient procedure, for that outpatient procedure, then I would just say in the documentation, they could type it in and go for it.
And pass it on, verbal.
Yeah, because that patient is going to be a full code during that procedure to phase 1, and then it's going to kick in after that. So you can actually reevaluate that time and have that order put in at that time and go from there if they're going to stay for a lot longer.
So would that order need to be put in before they leave phase 1 and go to phase 2?
If that's going to be the policy, yes.
Is there literally just a DNR in the order box
Mhm.
stuff? Okay, I just
Yeah.
haven't seen it.
It's a physician code status order that shows up. I actually don't know on your end where it'll show up, but
I haven't seen it come across.
yeah, they're always, if there's an order for DNR, there has to be a conversation charted. So you would see that the conversation could be charted in the pre-anesthesia note or whatever, and then the order to corroborate that. So I mean, it should be covered that way.
Okay.
Is this form available on documents?
Yes, it is now.
Well, and you said minimal documentation as for pre-op. What are you specifically looking for? Can we say yes or no's, or would you suggest we go through this with the patient and type it out?
Well, if we use this in those procedures, then you could just do this, because there's not going to be the wishes area for you to use.
Because
we
most
took
of our
that out.
patients do not have an advanced directive, they don't want the packet, so. I need to
And
know
this
what
is
questions
supposed
they
to be that form for that gap. So you could go through this with them. The big pieces, high liability pieces, and the pieces that can affect the patient's future more often than not are touched on here. So I mean, it is, do they want to be intubated? This is essentially the intubation question, but a lot of other stuff as well.
have.
And then it
Most
gets
of them
more
are like
restrictive.
selective ones.
So.
Most everybody said that second one.
So if this selective one, this is where this form gets easy for you guys. If they say they don't want some of these things and they only want these things, you hit selective and you get that physician in the room, because there's going to have to be an order that's going to accompany that change in full code status. If there's a change in full code, there always has to be an order and there has to be a conversation to corroborate that order. So if the patient does not go full here, and long-term, and pretty much accepting everything, then there has to be a physician-based conversation to change that.
So, and this is what you want us, I guess what, I just need to know what you want me to write in here for all these outpatient surgeries, all these endoscopies and all this crap. What do you want us to write for these people?
You wouldn't be able to do this form in pre-admit testing,
So what do you-
because
that's-
anesthesia has to talk to that patient, unless
So-
they have an anesthesia
So what do you want
consult.
me to do?
So
But then you say it's only for inpatients, you're not.
right now the first role is really for inpatients, because we, as we're getting into it, outpatient surgery is kind of a bag of cats when we're dealing with this
We don't know,
scenario.
we're not
Yeah.
knowing what we're doing, and I
So
just, I
you
guess
do
I want
have-
more detail.
Yeah, I did look at a couple, Timmy showed me a couple of your paper documents as of right now, and they work. Does the patient have an advanced directive or DNR, I think, is what is in there?
Yeah.
So those work for the time being. If you want to use this form, it's a completely easy way to do it, because again, if they are a DNR and there's a departure from it, there has to be a physician order and a conversation. So if they're anything but a full code, there has to be a physician order and a conversation.
Okay.
Yeah, which is difficult for surgery patients. But you'd hope that most of them would come in and say, I want all of this stuff.
Some of them do, a lot of them say that they don't want to be mechanically ventilated. So that goes into the selective treatment, and that's when I don't know how to document from there on,
So-
I'm like, okay, they do want CPR, but they don't want to be
Yeah.
mechanically ventilated.
I would think you would select selective treatment up there, and then when they came in for the procedure, anesthesia would have to have a conversation and document, well, we're going to suspend this during this amount of time.
Because you are
And
gonna
then,
be mechanically
yeah, and
ventilated.
after phase one, if you're still mechanically intubated at phase one, at the end of that, then you would terminate it.
So I would document it in the know, and then you guys would finish it in the same day, day of surgery?
Well, I would think so, because they're going to have a conversation. If the patient's not a full code, they have to do more in the note before the patient can do surgery.
Yeah.
Do you know if you can accept it partially?
Yeah, it will only accept it, well, yeah, you can, because it will only let you if there's not a document scanned. So you can actually only accept it as partial.
Okay.
Will only accept it as partial.
Okay, that will be fine.
Okay, back to inpatient then.
Yeah.
So I have a patient that doesn't have an advanced directive, so I fill this out and they say DNR, comfort, and no artificial nutrition by tube. Sign it.
Yeah,
Now, does the hospitalist have to have a conversation with them?
absolutely. It seems like that's multiple. Because that's a DNR, DNI order, and a comfort care order.
So, then multiple guests here, if they say, yeah, I want CPR, but I only want selective treatment, and I want a trial period of artificial nutrition, also a conversation with doctor. So the only time they don't actually have to have a conversation with them is CPR, full treatment, and long-term artificial nutrition.
Technically, that's not correct either, because they're supposed to still have that conversation with them about being full code. So really, what we're doing here is making it easier for you guys to do your job while covering up the liability for the facility. Because you're still able to have the conversation and get the big stuff out of the way. And then the physician doesn't really change their workflow at all.
Okay, so then, next question, we fill this form out, we scan it in, is the doctor gonna get like something on their worklist that says, hey, I need to talk to this patient, or do we have to go?
As
talk?
of right now, it's not set up that way, so it is just nurse talking to the physician.
Okay.
As of right now, I don't know what we're gonna plan on for that if that's gonna be something in the future or not.
So if we did an RN-MD communication, that would pop up on their work list,
I imagine it could, yes, I
have
don't,
this conversation?
yeah, it could, you could do it that way, yes.
Well, the reason I'm asking is because our hospitalists will sometimes disappear for hours at a time.
Sure.
I mean, literally hours at a time, and we don't see them for, and like last night, our hospitalist left the floor at 2 o'clock, and we never saw him again for
Okay.
the rest of the day.
Okay. So, I mean, I
So-
would guess that you could do something like that, or, you know, just chart that you made a phone call or something along those lines, because they're, at that point, you're responsible for filling this out and getting it in the chart with the patient, right? The physician is responsible for getting the code status orders in the actual chart and making sure everyone's on the same page, not you, physician, yeah.
Someone's a comfort one, do they still have to have this conversation and have an order in the computer?
Comfort ones are still valid in the state of Wyoming, so we could still do that. I would say that if they're Comfort One, I would still probably get this in here, just to have it on there. But if they have that Comfort One, there's a document that goes along with it, so if they have that, that can replace this. You can still just take that and scan it in and hand it back to them. It's a good question.
I have a question. When do you foresee the physicians in our community start utilizing the Pulse form?
So the copies are being made currently for our facility, because I can't really speak to the rest of the city, but the oncology clinics, pulmonology, and family practices request that they be in the first rollout as well. So they are going to be getting those end of this week and going through those with their patients. So hopefully we're going to start seeing more of a rollout. We are rolling it out phase 2 in pediatrics, and if there's a need that's noticed in like surgery clinic or something over in our facility, over in our MOB, then we're going to roll it out into those areas and get that conversation taking place there. Hopefully, we won't have to have this used on a lot of our inpatients, besides the surprise inpatient that didn't know they were going to be hospitalized at one point in time. But the rest of the town, I don't know. It has to be accepted in hospitals as a valid active order set right now. Currently in the state of Wyoming, it's valid and active. But that's only if it's filled out by the primary care provider or attending provider of the illness with those patients. So hopefully we'll start seeing it more often because it's easier for us. We just take it and scan it in and hand it back.
And so then my recommendation to my patients who have this is always bring it with them where they go. Again,
Yes.
like the file one. Okay.
Yeah. Any other questions? Okay, well, thank you, everyone.
Thank you.
Thank you.